Okay, thank you very much, Anita and Pablo, and thank you to Bill and the organizers of this session. I really am grateful on behalf of UNICEF for the invitation to speak at this session. I'd also like to acknowledge the traditional leaders of this land and all the people of Australia who have hosting us here this week. I was asked to speak about the realities of adolescent key populations. Adolescents, because while the session focuses on young key populations, we recognize that age group is very, very broad and with very, very different or wide-ranging needs. And so I'm going to focus in my remarks in the next 10 minutes on the younger of this group, that is, young people between the ages of 10 and 19 years of age. So I will cover what we know about adolescent key populations between the ages of 10 and 19, and then I'll talk about some of the opportunities for program and future research. So what do we know? Adolescent key populations are broadly defined in a number of groups, and this does vary from country to country, but mainly they include adolescents who sell sex, transgender adolescents, adolescent males who have sex with other males, and adolescents who use drugs. In all regions, these adolescents face an increased risk of HIV infection, as do their older counterparts. They're highly stigmatized, and they face exclusion from services, including HIV preventive services, protection, treatment, care and support, sexual and reproductive health services, due to the illegality of their behaviors or their sexual orientation, and their age, their very young age, often complicates their access to all of these services even further. One of the realities is that the data on adolescent key populations is extremely limited. Many of the behaviors that these young people engage in are criminalized in country after country, making not only service delivery, but service access extremely challenging for these particular young people. But it also makes research in these populations very difficult to conduct. Ethical guidelines on the involvement of very young children in research make it difficult to enroll adolescents in research. And that challenges us in terms of the insight that we're able to gather and the quality of our understanding about their particular experience. And so it challenges us in terms of our ability to design programs and services that truly respond to the needs, to their particular needs. So where we stand is that we do not have an excellent understanding of the number of adolescent key populations at national or global level. A study, for example, by the International Harm Reduction Association last year that was undertaken over the course of a full year tried to examine the experience, the numbers and experience of adolescents under the age of 18 who use drugs, and one of the critical findings from that is that they are largely invisible, and for the reasons that I've mentioned, their age and illegality. But from some surveys with limited coverage, from our various program experience at UNICEF, but also with other partners, and from data gathered from older respondents looking back at their experiences as adolescents, we know that there are many adolescents among key populations. Fortunately, we do know what works to prevent HIV infection, illness, and death, so we can act to address HIV in adolescent key populations. But in many ways, our greatest barriers are leadership and political will to change and confront the complex structural challenges that underlie the adolescent epidemic, and to some degree, the quality and amount of information available to help us tailor that effective response to adolescents in particular in each context. Still, some countries have attempted to conduct research to generate estimates of population sizes, to generate estimates of HIV prevalence, and other behavioral data. And this has been enormously helpful in providing insight into the reality of adolescent key populations. I'll give some examples. In 2008, as you know, the Commission on AIDS in Asia estimated that over 90% of new HIV infections in young people were concentrated among young key populations, underscoring the exceptional vulnerability and risk in these populations. The CDC has reported recently in the last couple of years that 1 out of every 4 new HIV infections every year occurs in adolescents and young adults between the ages of 13 and 24 in the United States. And 7 out of 10 new infections in adolescents aged 13 to 19 were among adolescent MSM. UNICEF has supported a number of studies with implementing partners in a range of countries to help generate better data on the realities of adolescent key populations in particular. One such study with the Institute of Public Health in Tirana, Albania, for example, explored the issue of injection drug use with adolescents who were street-connected, or adolescents who live in the street. The study was able to recruit 121 adolescent males to participate in the study, and some young people between the ages of 20 to 24. No young women or no adolescent girls participated in the study, again underscoring the difficulties in reaching even some adolescent key populations within that broad group. But what did the study find? 86% of the adolescents and young people had shared needles in the previous month, and more than 50% had injected that day. 1/3 of this group of 121 had tested for HIV, but none of the adolescents in the study, none of the young people in that group had ever tested for HIV. Again, linking back to the challenges in access to services for these younger groups. Condom use among the respondents at last sex was extremely low. It was only 14% with regular partners and 19% with casual partners. And one of the things that we found again and again is low risk perceptions and low access to information does affect preventive behavior in adolescent key populations. Over 1/4 of young injection drug users that were surveyed had never been to school, and 30% were homeless. A number of common issues emerge from the information that we do have, and I'll just underline a few more. Number one, underlying social and economic factors play a big role in contributing to the vulnerability and reinforcing high-risk behavior in adolescent key populations. The increasingly young age of injection drug use in adolescents in Eastern Europe and Central Asia, for example, has been seen particularly in adolescents in communities that are heavily affected by economic transition and high levels of unemployment. Number two, drug use and sale of sex by children very often go hand in hand, each one in some way being used as a coping strategy. And adolescents are as much at risk, not only of their own behaviors, but at risk because of the behaviors of their partners. Social exclusion and discrimination both drive and exacerbate the vulnerability of adolescent key populations. Social exclusion and discrimination limit full participation, dignity, and access to information and services. Punitive laws, punitive approaches to dealing with drug use, dealing with sexual exploitation, dealing with different expression of gender hurts children. It hurts children directly through withholding their freedom and rights to protection, and indirectly by separating these adolescents from appropriate care and support simply because they're perceived to be different or transgressing the law. I've mentioned the effect of low risk perception in terms of behaviors, but I'd also like to highlight finally the experience of sexual violence and exploitation, which are very, very common and lead to long-term effects in adolescent key populations. But the other reality is that many adolescent key populations become parents. Part of the reality is that the effects of exclusion and neglect of the needs of adolescent key populations continue to be passed on to their own children. A study, for example, across different regions of the Russian Federation found that HIV-positive mothers, including adolescent mothers, were 20 to 150 times as likely to abandon their children. And the reasons for child abandonment include shame, helplessness, negative attitudes towards single mothers, towards disabled children, lack of family support, violence, and rejection, all pointing to the continued need for protection, for care and support and access to services in these populations. The result for many of these children is many, many years in residential care or in institutions. And many of these children continue to stay in that residential care into their adolescence. Often, because of the punitive approach to drug use and the sale of sex, adolescents are incarcerated while they're pregnant or with very young babies, leading to the incarceration, ultimately, of the babies and young children themselves. And so I'd like to end with some opportunities and some opportunities for both our programming and research. The most important opportunity for all of us is that adolescents themselves and young people are active and experts on their experience, and their participation really adds enormous value to our programs. In the absence of data from large-scale trials, from large-scale surveys, the participation of adolescents and young people can help serve as a bridge between programs and services that aim to reach them and the adolescents themselves. Laws, policies, and social norm change all can benefit from the engagement of adolescents, from community-based organizations, and from entire communities to try and ensure that we address those, the protective environment. And finally, the opportunities from our research really lie in strengthening our data and using implementation science to better understand, with the smaller numbers that we are reaching, how to better deliver the services and the protection that will give us better impact in terms of reduction of HIV transmission, illness, and death. Thank you.